Okay, some EMS case reviews here. First case, patient went to the Battle Run Clinic after not feeling well for the past 2 days. Wheeled in wheelchair to exam room. Husband saw her go unconscious and ran and got the staff. Staff was by her side immediately and found her to be in cardiac arrest. They applied an AED, began CPR with someone else called 911. Staff shocked patient one time and patient began to come to. Fire arrived shortly. Patient was attempting to talk. On arrival, patient went unresponsive. The CPR was begun. IGEL was attempted just before the shock was given. At that time, the jaw was clenched. CPR began immediately. After shock, patient began talking and saying, "Stop, it hurts." That was about 40 seconds after the shock. IV attempted on scene without success. 12 lead completed and vital signs on scene. Patient moved in the car, placed in a gurney. Patient stated she could not chew aspirin. Nitroglycerin deferred due to possible right-sided MI. Patient did not feel like she could have anything in her mouth. The patient was only complaining of chest pain where the compressions had been done. Fentanyl was given. Patient didn't want anything any more than the first dose. Patient was repetitive questions, didn't remember going to the clinic, was concerned about where her husband was. Denied having any cardiac medical history, transported code 3 to Southwest, remained unconscious, talking all the way, felt nauseated, Zofran deferred due to Zofran's long QT as a possible side effect. An interesting thought, but we'll talk about that. IV established en route, vital signs and detailed exam as per flow. So, initial CPR, EKG, VFib, defibbed after, so that's the second defib. One attempt at IV unsuccessful. 12 leads showed suspected inferior STEMI. I don't remember seeing a V4R, V3, V4R. Got some fentanyl, pressures stay fine. Got another dose of fentanyl, so got a pretty good dose, which is probably why the nausea. I don't think I would, it's fine not to give her the Zofran. Now, this of course is a code save. In the hospital, she did have an inferior MI, so my comment was it's good to withhold nitro. Also, blood pressure was below normal, so with the other hand, fentanyl was a good choice. She went urgently to cath lab. She had a right coronary artery occlusion stented with a drug-eluting stent, and doing well, and was discharged literally the next day. Yeah, she still complained, by the way, of chest pain from compressions. I don't recall. She didn't have any fractures, though. It's not uncommon that we get fractures after CPR. I'd like to say it's because of the citizen CPR or the other staff CPR.
At least she's alive to complain about.
Yeah, she's alive to complain. It is an interesting complaint. It's like complaining about the scar from your cricothyrotomy if you're alive. You know, it sort of tells you something. Dispatch code 3 on the cardiac arrest arrived to a private residence to find police, law enforcement on scene, performing chest compression on a 71-year-old male, supine on the floor, agonal respirations, 4 to 6 per minute, pulseless, unresponsive. Per family, patient was normal 10 minutes prior, was on the couch when he became unresponsive, was unable to move the patient to the floor. Family. First CPR by police. Chest compression with Lucas device was applied, rhythm check approximately every 2 minutes, no RSC on scene. Agonal breathing throughout resuscitation appeared to correlate with administration of epi. Code 3 transport to Peace Health. Lucas device used during transport. ROSC during transport for approximately 30 seconds. Again became pulseless, Lucas device resumed. For remainder transport, patient care transferred to staff in room 33. So mechanical compressions, PEA, eye gel, asystole, pulse ox, 85%, CO2 50, epi, PEA, epi, PEA, epi, PEA, PEA, normal sinus rhythm, briefly CO2 is 53, and then chest compression started again because it went back to a PEA. Got more epi, so we got 1, 2, 3, 4 doses of epi. In hospital, this is my review again. Patient got pulses for about 6 minutes and then rearrested. Got pulses back after another dose of, I meant epi, not atropine. Required pressors to maintain blood pressure. Had bright red blood per rectum. Patients on Coumadin for chronic AFib. Was sent to the CICU on controlled temperature management, which is the magic term now for hypothermia, and mechanical ventilation. Very guarded prognosis due to long downtime and long time to get ROSC, 40 minutes. Huge amount of epi, altogether 6 milligrams. Now, this is my question. Now, at the time, I have to follow up. My question is, should he have been transported? Because we did not have ROSC at the time he was transported. He was simply on mechanical ventilation, and that's not a reason to mechanical compression. That's not a reason to transport. He was witnessed, but he wasn't in a VFib arrest. He's always in the PEA, and I like to work the PEAs at the scene. If you get ROSC, transport. If you don't get ROSC, don't transport. Now, so that's what I just said. Reading my notes here. Now, I like to work the PAs on the scene, including going through all the H's and T's, thinking about the H's and T's. So, in this case, because of his age, because of his downtime, because of his, before we got ROSC, I probably would have given him some bicarb. And I probably would have even thought about giving him some calcium because he had, we don't have the strips here, he had a kind of a wide complex PEA. Theoretically, there's a, in actual, but I mean, old guys have renal problems, have kidney problems, they have, and you end up with, and he's been on Coumadin, he's got atrial fibrillation, he's got chronically, he's got a good reason to have some chronic renal issues. Also, of course, you didn't have bright red bleeding, rectal bleeding visible at the scene, but he needed a fair amount of fluid. So I probably would have worked him up, and indeed he had evidence of severe anoxic brain. It's a long resuscitation. I mean, 40, 50 minutes before you have effective ROSC, and then you have to maintain his blood pressure, and then you've got so much epinephrine on board. People just don't, they always, in my experience, they almost always end up with anoxic brain. So, anyway, ultimately, he was, the family elected for comfort care. They removed the ventilator and literally expired on the spot. This is a 63-year-old male, chest pain. Patient states he was outside pruning a tree with his hands above his head, and he started having a burning chest pain on the left side. Went inside his house, sat down at the table to relax. After about 10 minutes, the pain got worse. He states he has never had cardiac issues, states he had multiple family members with various cardiac issues, including valve replacements and stents, Says he took nothing for the pain. He's conscious breathing, sitting at the kitchen table, warm, sweating profusely, moved to cot. Defib pads are placed. He has a GCS of 15 throughout. One paramedic firefighter is taken for assistance. 12 lead at 1520 V4, V3R. He has several 12 leads, which is nice. I love it when you give me enough 12 leads to back up everything. Patient claims to have some relief with fentanyl and nitro. During turnover of care with the doctor and the cardiologist, patient goes into defib VTAC and is shocked, and then VTAC, and he's shocked both times. So that, wow, this is handy. He's right. And then they can't say, well, have you got a strip for me? So he woke to a GCS of 15 and says, gosh, I feel better. So, pain, yeah. So he was brought in the STEMI alert, which is why he had the ED doc and the cardiologist there. Nice. Got a sinus rhythm, got some nitrospray, his CO2, he was hyperventilating a little bit, CO2 of 18. Any rate, I was a little confused about the times recorded, but it's just a time. It seems to me that if you're recording your times off the life pack, that should be as close to possible as true. So, any rate, I don't appear there, so it was really trying to figure it out, because it looks like they started transport about 15 minutes after contact with the patient. That's not what I interpret from the narrative. Meds seem to begin a little late, if that's recorded correctly, so it's be careful about it. Because I do look at all that stuff and try to figure it out. Seems it was a long time before nitro was given in a major hypertensive patient. He was quite hypertensive with angina, so he really could have handled the nitro. So he went to the cath lab urgently, delay only to stabilize from the VTAC arrest in the ED. In cath lab, 100% occlusion of the dominant right coronary. So it was dilated and stented with a drug-eluting. You know what a drug-eluting stent is? They put the stent has a coating inside it of basically anticoagulant to keep it from, to try to keep it from occluding again, from getting another clot. He continued, well, he's awake, you're awake in the cath lab when you're doing all this. And he says, I still have chest pains. I'm really having chest pain. Well, so they continued on with his thing. So they did the right coronary catheterization because that's where we expected to find the culprit lesion that was giving him his right-sided MI at that time. But he's still having chest anginal pain. So they go ahead and do the left cath, because they would do that as part of the cath technique anyway. And the left cath showed a 90% occlusion of the circumflex branch. Did I say that he owned a Burger King franchise? No. So this was dilated, and then he said, hey, I don't have any chest pain anymore. So he had a 65% ejection fraction at the end of the procedure, which is about as good as you can get. I mean, most of us on a normal healthy day would be happy to have 65. I'm happier with 85, but so he went to the CICU, post-op, unremarkable, discharged next day. Probably in a statin and also changing his diet a little bit. So he kind of lucked out because he basically had 2 deadly lesions, one of which brought him to the attention, and he survived it. Case 4, per hotel, they found the patient down on the floor when they went to clean the room. Hotel says the patient was not responding to them, so they activated 911. Off-duty EMS, they found the patient face down and rolled her over to find her breathing not effectively with her eyes open. Her husband, by a phone call, they've been having marital problems. She's been in a hotel. Husband states the patient has no medical history, is aware of, and does not take any medications. Scene was in a hotel room with emesis on the bed and a medium-sized spot of blood on the floor. There were a few boxes of white wine and an empty package of Benadryl and nighttime cold medicine. It's unknown if packages were taken all at once. What's your guess? Patient was on the ground, not talking, randomly moving extremities and body. Patient in an initial low sat and had to have assisted ventilations, vital signs within normal, EKG normal sinus due to patient size and short neck. A C-collar was not placed, and towel rolls had to be used to secure the patient. So that's good. You're protecting the C-spine because she obviously face planted. RSI was elected due to AMS. After 2 attempts from providers unsuccessful at intubation due to large tongue, excessive adipose tissue around the exterior neck, short neck, edematous soft tissue in the airway, unable to see direct laryngoscopy, unable to see landmarks of airway, unable to pad shoulders due to being in full C-spine. Anything else we could have complained about? This is a difficult airway. So, an eye gel was placed to obtain appropriate EtCO2 and SpO2. And that's the way it should be. So, pulse ox was 90%, then 98% on O2, got naloxone, okay. CO2, 32, then she got, so now her O2 set's 98%, and it started out at 1208, and at 1221 she got some intolerant. They're electing to paralyze. Now I don't know, I want to see an O2 sat before you paralyze. I'm assuming it's going to be okay. It was at 98% already, but I'm not, I can't assume anything. Now the CO2 is 8. Got some succinyl choline. I don't know if that's accurate. The CO2 next is 15. Intubation unsuccessful. Unsuccessful. Got esophageal. The CO2 starts kicking up to 68. I don't see what an O2 is at that point, but an eye gel is dropped. Now with that, and got some midazolam, and with the CO2 of 47 and the CO2 and the 42 and a pulse ox of 97, I'd say we're winning. Got some more midazolam. What should also we might have done?
My card?
Did I give this? Okay, you get a pass. You don't have to come to the next meeting. In the hospital, okay.
That's no
So I'm
audience. You're out
good.
of
This is
luck.
good field management, difficult patient to intubate, and the choice to use the eye gel after 2 failed attempts was appropriate. Good CO2 and good PO2 noted afterwards. Was there suction? I don't see it recorded in the flow sheet. Patient likely aspirated altogether, probably not because of anything we did, but just the fact she's unconscious, or she's unconscious, not able to protect her airway, and it's in the ED she was immediately intubated. X-ray and CT showed nasal fractures, CT evidence of aspiration, blood alcohol high, also likely OD on NyQuil and Benadryl, hyponatremia due to the alcohol and prolonged QT syndrome. So she's set up for a VTAC episode I would, and it's another, so this would have been a good place to use bicarb with the presumed Benadryl overdose. You're never gonna get in trouble with me if you say, yeah, I thought maybe we're gonna cover because I thought she had an overdose. In the ED, she started to awaken. She was kept on a ventilator for aspiration and sedated until the toxic effects of the Benadryl and alcohol wore off. They did give her some bicarb after the time. So, all right, end of that. Now I'm going to get out of this and go to protocol changes. Word. Protocol revisions. This has been added. You probably haven't reviewed the things. We had to, you know, we did the review, did the whole state study with the Travis Alert, the disabilities, disability patients. As we were rereading the law, not only did we have to present this in a PCEP format or an all-person format, we had to write a protocol for it. The protocol just has to include the disabilities checklist. So it'll be in your protocol. You can read it at your leisure and pleasure. And you know, so if you're dealing with a patient that has a disability or apparent disability, do your universal patient protocol in evaluating the patient, and then if the disability is present or obvious, reported or suspected, go to the disability checklist reference. Immediate actions in that are safety of EMS personnel, bystanders, respect patient space, include the patient in planning and decision-making, assess and treat immediate life threats, what physical barriers need to be removed, consider the need for outside resources. Then go to specifics of that patient's specific disability/ability. So if they have mobility or physical impairments, assistive devices should accompany the patient when possible. Arrange for alternative transport for the device. If you can't transport it, find a method of securing the device. Consider using the same method of transport the patient has used in the past. Request other resources. Vision, sensory impairments. Determine the degree of vision deficit. Speak directly to the patient. Don't shout or use non-specific, like, watch out. Determine if assist devices or service animals are used. If they have hearing impairments, determine the degree of hearing deficit. Determine what communication techniques are best to use. Look for someone to help you communicate, or use a family member or other resource immediately available. Mental health, cognitive abilities. Check the blood sugar. Consider the differential diagnosis, medical, traumatic, etc. Toxic. Avoid sensory overload or triggering actions when interacting with the patient. Vancouver fire crews had and some of the AMR had a session this morning with law enforcement on de-escalation techniques and de-escalating mental health issues. Use a calm voice, avoid escalation, use open posture, avoid prolonged eye contact, consider other resources for safety. Autism, avoid sensory overload, triggering actions, sounds, bright lights, etc. Discuss requirements for successful interaction with the caregiver, if present. Use a calm tone, acknowledge and validate emotions. With service animals, assure the service animal is transported with the patient. Request additional assistance if for some reason the service animal can't accompany the patient. Okay. I'm going to bing down to this last one first. A couple of housekeeping changes. Activated charcoal, we're still carrying it, but it's only for aspirin and APAP, acetaminophen, Tylenol ingestion per poison control or medical control concurrence. Supraglottic airway and cardiac arrest, we already talked about. The majority of patients transporting cardiac arrest or who have achieved ROSC may be managed with an SGA. I'll talk more in a minute about that. Opiates with respiratory depression, that's added to the poisoning overdose protocol, just a housekeeping change. Pleural decompression, you may or may not believe it, but we were asked, should we leave after we needle the chest, should we leave the catheter in place? Yes. That's the whole point. Chemical restraint is now in the pharmacologic session and includes ketamine for pain. We allowed for repeat dose in pain control as an adjunct with opiates. You use fentanyl 0.5 milligram per kilo given over a couple of minutes, probably a minute. Maximum at 25 milligrams, but can be repeated. Also, if you're using it with the adjunct, as an adjunct with the opiates, you need to have given at least 2 doses of opiates before we're okay. So if you get 50 of fentanyl and 50 of fentanyl, then you can add it. Severe pain or pain with hemodynamic instability, 0.5 milligram per kilo IV or IO over a couple minutes, max at 25, but may repeat to control pain. Or a milligram per kilo IM may repeat every 30 minutes. That's kind of the military dose for battlefield stuff. Precautions in adults, this was brought up by, in adults you'll occasionally see emergence reaction side effects, minor hallucinatory kind of stuff, and that's usually treated well with just a low dose of Versed, maybe 2.5 IV or iron. With the kids, it's usually not necessary. So let's go back to the big one here. Okay. Now, I'm going to run through this intubation procedure for RSI and for DSI, delayed sequence. Now, it won't be in effect after we get this done. I just want you to be aware of it. We're starting it now, and we're going to do a whole series of train the trainers later this month and next month until we're done. So it may be February or March, we will have small group sessions where we will have fire and transport personnel training together to the DSI technique. I know you know the RSI technique already, but that'll be part of it, because DSI is a logical extension of RSI. The basic rule is you've decided that you need to intubate this patient. And you decided that you're going to RSI the patient, you're going to use paralytic assist. Then it's just a logical extension, we'll get into that, but don't get excited, we're going to have, so you will have small sessions, we'll do scenario-based training, and when you're done with the training, then you'll be signed off to use this in protocol. The reason we're going to go to delayed sequence is that it takes care of those this is to manage those patients that you can't adequately get their SpO2 up prior to entering the intubation portion. And we have a significant number of these people, and you know who they are. They're mostly respiratory. They're mostly they're COPD or congestive failure, or when you get there and they're tripoding, they're having a terrible time breathing. They've got a O2 sat of 85, and they resist everything you're doing, and you can't get their O2 sat up, and you say, logically, I need to get an airway in this patient, I need to ventilate them adequately, and you sedate them and paralyze them, and all of a sudden their O2 sat begins to drop out, and they brady out on you, and they either go to profound bradycardia or they go to arrest. So we're dealing, that's a small portion. Most of your RSI patients will go smoothly into RSI, like the one we talked about here earlier. O2 sats were fine, patient was fine, didn't do a thing during the intubation process, even though she couldn't be intubated. She then handled the iGel, which is also in this protocol. So, basic intubation protocol. There's two things. One is cardiac arrest intubation, which is different, but for patient perfusing requires sedation of paralysis. That's your assessment, your crew's assessment is this patient we need to secure an airway in this patient, for whatever reason. So, we'll go into the intubation, and we clean the intubation procedure up a little bit, assess scene safety prior to considering advanced airway procedure to intubate, analyze risk of procedure and its benefits. Now, there's no checklist, that's an analysis, that's your team working on this. So what's the problem? Establish adequate 360-degree access to the patient. Note, this is difficult to do in the back of an ambulance, especially if it's configured so that the gurney is against the wall. If it's in the middle and you can move around the patient, that's a whole different thing. Note and document the patient's GCS and neuro prior to administration of